60? 61.
61 years old. The underlying disease was hypertension. So she complaint was 2 weeks PTA. He was fall and fall on his right hip. So 2 weeks PTA. Doing like.
Can you specify the mechanism of injury again?
So
What kind of fall?
He fall like.
Fall from standing, fall from motorcycle, fall from stairs.
Fall from standing.
Fall from standing.
Yep. Doing like he take like his car for walk and then it was like slip over and then fall on his right hip.
Simple fall.
Yep. So
ลุงล้มธรรมดาเหรอฮะ
ล้มธรรมดา
ล้มธรรมดากำลังทำอะไรนะคุณลุงเลี้ยงวัวอยู่แล้วก็
จะเอาวัวไปล่ามไหมจะไปปลูกนะเหยียบวัวพันขา
อะไรนะมันพันขา
เชือกมันพัน
วัวมันบินไป
มันดึง
พาดขาลง
อ๋อพาดขาลุงแล้วลุงก็ล้มลงไปแรงไหม
ล้มแล้วไม่รู้สึกตัวพอมารู้สึกตัวอีกก็เดินได้นะไปได้
โอเคfalling
So after that it was like mild swelling on his right hip, but he can walk and he complained of mild discomfort of his right hip, but then he can like walk normally. And then so one day PTA.
Limping or not?
Then he said that he can walk like normally, no any like abnormal pain.
ลุงหลังจากล้มคุณลุงเดินปกติหรือเดินกระเพก
ก็เดินก็
วันแรก
อาการแป๊บอยู่
แป๊บ
ไม่ได้
เดินกระเพกไหมหรือเดินธรรมดาเลย
เทียนขัดแน่
ขัดเดินได้แค่เป็น
ขัดแต่เดินได้ปกติใช่ไหมไม่กระเพกนะลุงนะ
ก็ไปทำงานถึงวันที่
อ๋อทำงานได้
วันที่21ขึ้นมาอาบน้ำล้างออกจากห้องน้ำขามันจะพืดไปอย่างนี้ก็ไม่รู้สึกปวดขึ้นมาเลยเพราะ22 23ก็มานี้เลย
Me like shear off, but then he didn't fall. So after that he like felt of immediate pain with the pain score 10 out of 10, and then it was like mark swell over like his right hip, and then he should not walk or like.
How many days before?
1 day with PTA. So he come to the hospital.
So that's another injury.
Yeah, but the last injury he didn't fall. It's just like slip. Yeah, and then like he like experienced of like immediate pain. Come at his like right hip.
รอบ2นี้เจ็บเยอะใช่ไหม
เจ็บเยอะถึงได้ไปเอ็กซเรย์ที่คลินิกหมอเพราะว่าขามันหัก
ลุงดอนสิครับ So from examinations ลุงยืดขาตรง
Firstly, from the examination of his right leg, so his right leg like was firstly it was like shortening for 1 centimeters, and the leg was externally rotated.
You mean initially, right? At the emergency room.
Yeah.
It's shortening around
1 centimeter.
1 centimeter.
But the pulse was good. The palpitator pulse was like 2+. Also, dorsal pedis and posterior tibial was 2+ as well. The motor function was good. He can do like grade 5 of plantar ankle flexion and also like ankle dorsiflexion as well, and also like toes flexion and toe extension. But from the yesterday examine, I examined him, but he on the skin traction, so I didn't examine the knee, so I didn't know like the range of motion of the knee.
Okay. So where's the pain? He's complaining. Where's the pain?
He complained of he tender at the medial groin.
Front or back?
At the front.
At the front. Okay. So whenever the patient complaining here, ลุงเจ็บตรงนี้ใช่ไหม? He's complaining pain in the front. You're thinking about a hip problem, right? Sometimes the patient complaining pain in the back, and the patient say, "This I have hip pain," but most of the time it's not the hip problem. What's the problem? The patient complaining pain in the back, chichano?
In the back.
Huh?
In the back, right? I think all the chloride point.
So if the patient complaining pain in the back or gluteal pain, we call this groin pain and gluteal pain. Gluteal pain most of the time is coming from the back. Sometimes radiate beyond the knee. So that's a spine problem, lower spine problem. But if the pain is in the front, you're thinking about hip, right? So this patient complaining pain in the front, right? Okay. So it's very common in elderly. I think number one for the elderly patients that this type of injury, we call the hip fracture, right? So the hip fracture, there's two kinds of hip fracture. Is that?
Neck fracture.
Fracture neck of femur and
the
intertrochanteric fracture. So you need to differentiate because the line of treatment is totally different. But actually the fracture line is just 1-2 centimeters apart. But the treatment prognosis totally different. Okay? So from clinical, how can you differentiate these type 2 fracture? So here. So he's falling, the history, common history is falling, pain, limping, cannot walk, right? And sometimes you can see that some shortening. So what's the difference between these two kinds of fracture?
In terms of the anatomical side, or I think if it's the fracture at the neck,
now you're going to differentiate between those natural history or anatomy?
Anatomy.
Anatomy, okay, let's talk about that.
So for the femur, if the vascular supply, at the neck there's like less vascular supply.
Fracture neck have less vascular
So
supply.
there's increasing risk of like a vascular necrosis following a fracture.
Yeah.
Yes. And so in terms of like the.
You have iPad? Can you draw? Make a blank. Yes. So the fracture neck, you have said, you mentioned that they have less vascular supply, right? Okay. Okay. Draw and tell me. Draw a picture. You hold that for you. Draw a picture. And why? I told you. So this is the femur head, right? And this is the neck. It's the canter. This is the socket, right? So you said this is a fracture neck, right? And this trochanteric fracture. Okay? So actually the fracture neck we also classify into, we call this subcapital. Subcapital, that means it's just underneath the head. Transcervical. Here, transcervical. And this is the basilar neck. You see, the level is very close. Oh, sorry. Okay, this is the basilar. Okay, and the lower is the intertrochanteric. Right? You see this area. Just few centimeters, you can classify it into 4 line of fracture. So which one have the best prognosis for the vascular necrosis? Which one? Yeah, the intertrochanteric fracture, right? And then basilar. Okay. transcervical and subcapital. So if the fracture line, number one is the fracture line, it is very low, close to the trochanter. You have this circumflex artery, right? This one? Yeah. You have the circumflex artery around this area. So this area is rich of vascular supply. So the fracture line is close to this. There's still vascular supply to the head. Okay? But if the fracture line is more proximal, so the vascular is only just to this area. This is the lateral cervical artery, lateral ascending cervical artery. So the vascular supply is very minimal, right? And also, so if the fracture line is like proximal, transcervical, subcapital, so you tend to have the vascular necrosis. So it's also depending on the location and also the displacement, initial displacement. If the patient have non-displaced fracture at all, that means like incomplete fracture, the chance of avascular necrosis is also lower. Okay? Understand? This is the vascular supply to the head. So you need to differentiate. This is fracture neck. Fracture neck femur in elderly, we tend to do the arthroplasty, we call the hip arthroplasty. Okay? But if the fracture line is close to the trochanter or close to basilar neck, we tend to fix it with the screw. Okay? Screw fixation, because this can heal and you have less chance of avascular necrosis. Okay. From clinical, Charissa, what's the difference between these two kinds of fracture? From clinical. This is, he mentioned about anatomy. You mentioned about clinical. And next one mentioned about the themes. Okay? And another one mentioned about the line of treatment. Charissa.
Maybe the patient, like whether they have osteoporosis or not. If the patient has like osteoporosis, then they may have a high chance of having the femoral neck fracture.
Okay.
And also maybe it depends on the age of the patient.
Yes.
The older patient, like the older end.
Older patients tend to have
Femoral neck fracture.
neck or throat. The older one. Intertrochanteric fracture. It's more common in the very elderly patients. Okay? So that's by incidence, but anyhow, this can happen in both age. You know. So the older one tend to have more intertrochanteric fracture. And how about the clinical pictures? So what is the classic clinical pictures of the hip fracture? Groin pain and
also like
shortening, external rotation, flexion, external rotation, right? Like this position, okay? But this one under traction, so that's why he can maintain in this position. Okay? So the patient tend to come to see you like this, okay? Slightly abduction and external rotations like this way. Okay? So this is the clinical picture. What else? So both we have these pictures, intertrochanteric fractures, also the intertrochanteric fracture or neck fracture. Shortening, external rotation. What the difference between these two? Sometimes you can tell. The gait. Actually no, because the patient come to see you at the emergency room, they cannot walk. Okay, they cannot walk. Ecchymosis, what the difference? Why? Why? Change to the new one. Because you know the hip capsule, right? For this. So this is the neck fracture. Trochanteric fracture. This is hip capsule. You know, the fracture neck of femur, okay, is this intracapsular. So the bleeding will be inside the joint. There will be no ecchymosis. But trochanteric fracture is outside the joint, outside the capsule. So you may see that the patient may have ecchymosis around the hip joint. So if you see ecchymosis around the hip joint, it tends to be intertrochanteric fracture. Okay? So ecchymosis. What else? Shortening. The fracture neck is in the capsule, so it's in the limited space, right? So it's rare that the patient will have severe shortening because it's inside the joint. That's I mean in the acute situations. But in chronic situations, sometimes the patient may have the like a wear, or there may be some resorption of the head, resorption of the fracture side. You can see some shortening also in the chronic fracture neck. Okay, but different from the intertrochanteric fracture, so there's no capsule. It's not in the limited space. So you can see a lot of shortening comparing the fracture neck. Okay? So these are the two difference between the fracture neck and trochanteric fracture. Okay? Okay, Nene. So how can you manage this kind of fracture? So when you see this patient at the emergency room, what's your plan? If you're the first doctor.
I'm the first doctor. So then I have to see
Louder?
if it's
No. Close it.
we need to stabilize the fracture side
Mm-hmm.
and then see if
First, okay, you stabilize the fracture, immobilize.
immobilize and afterwards you see if it's like if the patient needs surgery or like you can do conservative treatment. So maybe like skin tractions and things like that.
Then you send patient for X-ray. After you request the X-ray.
After the X-ray, you can see if it's like
No, request the X-ray.
Oh, request the X-ray. I would ask for
Request.
both hip, AP, and lateral crosstable.
Both hips, AP, and
Lateral crosstable.
lateral crosstable. Okay. So do you know how to do lateral crosstable?
The beam comes from this way.
Show me.
So the beam comes from this way.
So
Like
this
from-
leg will obstruct the view.
Well,
Hmm?
you have to bend the knee of the lateral of the
Yeah, you need to do this way. Okay. คุณลุงโทษนะยกขานี้ขึ้นยกตรงๆยกสูงๆงอสะโพกงอจับเอวไม่โป๊ลุงยกขาขึ้นมาสูงๆไม่ใช่เอาขายกลอยลุงยกลอยปล่อยขาที่ปล่อยthis way. Okay. So you put this up, that will not obstruct your view, right? And check the beam this way. Okay. For hips AP and lateral crosstable. Okay. So shoulder films and nappy bone wriggle films. Stay here. Not obstruct your face. You stay here.
So this is the beam of AP portrait. And for the tissue that I like osteoporosis seen.
How can you tell that?
There is no like high density of the bones around here, but
Tissue thin.
around here there are the hyperdensity of the cortex, and there is
You see cortical thickness, right?
Yes.
You see? It's cortical thickness. And this is the man. You know, the man tend to have less osteoporosis. See? The cortical thickness is so nice. Look like a young man. See? And you see this trabeculae? What is that? What's that? You can see clearly on this side. We call this the principal compressive trabeculae. You see trabeculae? You see another one, you see this line? This is the tensile trabeculae. And this triangle we call the Watt triangle. Okay? So the key trabeculae is this one. The principal compressive trabeculae. You can see it very clear, right? You can see it very clear. And this trabeculae is also the line that you can see that the fracture displaced or not. Because in normal people, this line will be like 180 in straight line. You draw the line from the calca, right, to the head. You can see that this line is straight. How about this one?
There are the disruption of
Disruption of
central line.
Central line. Can you show me? Where's the disruption?
Disruption between this one and this one is not continuous.
Yeah, this one. You see some stepping here, right? And you see that fracture lines here. How about the principal compressive trabeculae?
There are some like displacement, but it's not that obvious.
You see this line?
Yeah, it's
This line is still in the same line, right? Yeah. If it's displaced, it will be like this, angulation. If the angulation like this, we call Wallace angulation. If the angulation is like this, I mean this line, it's go this way, this is Walker's angulation. So can you find the, in the internet, the Wallace and Walker's, show the students. Okay? So you can see this line fracture. Is good or not?
No.
What is this one? Is this subcapital, transcervical, or basilar neck?
This one is.
What do you think?
I think it is the basilar neck.
Basilar neck? Are you sure?
No.
Change your answer again.
The cervical.
Huh?
I think it's subcapital.
So that's the head, right? Transcervical will be here. So you see the head is here. This is subcapital. Actually, if you have the traction view, it would be good because sometimes there's something like in the positions of the bone is shortening. So it's good if you have like.
This is valgus.
Yeah, it's the valgus. You can see the alignment. This is valgus. You see the principal compressive trabeculae? It's valgus, right? It's different from this one. So this one, the alignment is like reverse. So this is valgus. Okay? Valgus or Wallace, which one is better? Valgus or Wallace? Valgus or Wallace? Chalisa? Chongquan? Valgus. Because in type 1 we call the impact valgus. Okay? So it is like this. This is good. Because the head tends to go this way. So this is valgus. Valgus most times is good. If you want to reduce the fracture, is it not anatomic, you prefer to go in valgus. Okay, show me again the Wallace. Okay, this is subcapital. Next. What else? How about the lateral crosstable? So let me pause. What do you think?
You see the fracture line
Fracture line and
the displacement.
where's the displacement? To the front or to the back? Where's the front? Where's the back? So our femoral head, we have lateral version or anteversion? Anteversion, right? So this is anterior posterior. This is anterior. This is posterior because the trochanter is in the back. The head projecting to the front like this. Called anteversion. Our hip is like this, anteversion. If you go this way, this is lateral version. So it's projecting to the front. But the fracture line, you see fracture line, and you see some interposition here. That means the head moves to the front or to the back. To the back, right? You see that here, the head is some interposition. So this patient have the displacement of the fracture to the back. Okay. Understand? So there's a displacement also, right? So what's your plan? What do you want?
So this patient has at least, for the displacement, like at least gotten 3 and 4. So the plan is to having the surgery. And we have to ask the patient about the history of alcohol and cognition function before the surgery, because if the patient is alcoholic, maybe this placement of arthroplasty might not be the choice. Maybe consider like bipolar fixation.
How about fixation for him?
This one is 60 years old. Maybe the multiple screw fixation might not be the choice also because
You judge by the age.
yeah, we have to see whether it's less than 60 or more than 60 years old. If it's more than 60 years old with the active motion of the hip, like he is still active, maybe the arthroplasty might fit for him.
So first, it's not the age. So you judge by the type of fracture first. Okay. If this kind of fracture is like fracture type 1 or valgus impact like that, non-displaced, even she's 70, we still use the multiple screw fixations. So number 1 is not the age. Okay. Number 1 is the type of fracture, the degree of displacement, okay, and then the age after that, you know. So this patient, the fracture line, I think this line fracture subcapital, also there's some displacement. And if you see the alignment index, we call this the garden alignment index. Is it in the same line? It's not good. That means this fracture is completely displaced and the head is getting to its position. So the alignment will be in the same line like previously. You know, this is complete displaced fracture. You know, but this is still non-displaced or incomplete displaced. You can see some angulations. Okay, like type 3, you can see some wallets. In type 4, the alignments will come back to like normal. It looks good, but actually this is not good. This is type 4. Okay? And also this subcapital, complete displaced. So the chance of vascular necrosis is pretty high, and also the chance of non-union also very high. That's why we choose the choice for him, the arthroplasty. Okay? The arthroplasty, actually there's 3 types of arthroplasty, but you did not need to know, don't need to know in details, right? There's a unipolar, bipolar, and total hip arthroplasty. Okay? So we just by the quality of life, also the ambulatory status of the patient. Yeah, this guy is very active, and also he has good bone quality. Yeah. So I think bipolar or total hip arthroplasty should be good for him. Okay? Because if you use the unipolar, you may tend to have the protrusion and draw a line. There's the 3 types. This one is very obsolete. We call the unipolar arthroplasty. The stem is like this. Okay. It's we call the unipolar arthroplasty. Okay. So this is like one system to the hip. What's the problem, you know? Yeah. So this like a bone on the cartilage. So we use this in the past for the very elderly patients. no walking. Yeah, so this got hip. It's okay. It's simple and also cheap, but the problem is that this area, the acetabulum will have the wear, okay, because of the bone on cartilage. So finally, this space will be narrow and the prosthesis can protrude, and there will be some wear of the acetabulum. We call the protrusio acetabuli. Protrusio acetabuli. Okay, so it will be wear to the acetabulum. Okay, so the next system is like bipolar. Okay, you have here, and also you have the small one inside. The step will be like this. So this is the socket. Okay. So when the patient moves, it's move in the smaller one, but this big one will not move. You know. So it's like you have two liners, right? This one and this one. We call this bipolar, right? Hemianoplasty. Okay, but anyway, some articles also mention that this sometimes also move together. Yeah, they still have some protrusio acetabuli also. Okay, but this is better than this one. Okay, so this is we call the bipolar. Okay, bipolar hemianoplasty. Okay, so we call this unipolar, right? Unipolar, bipolar. Right? Next one, and the last situation is this one. Okay, you fix this to the acetabulum, and you have this one. So this one acts like the socket, right? And this is the, so this is the total hip hypoplasty. Okay. This is good for the, because wear of the total hip comparing to the hemi or unipolar is less, and also you have the 10-year survival. Okay, better than the hemi or unipolar. But anyway, this is good if there's no dislocation. But the chance of dislocation of the total hip comparing to the hemi or the unipolar is higher. So it's good if there's no complication. Okay? So this is the another option. And the trend today, if the patient is still active and longevity is the patient still very active and they have no other disease, they stay longer, we prefer to use the total hip arthroplasty. Okay. Good. So today we plan to do the surgery for him. He's still active. คุณลุงแข็งแรงดีเนาะโรคหัวใจอะไรไม่มีเนาะ